Good morning, Krishni. I can confirm that we are now live streaming.
Thank you, Tom, and good morning, everyone, and welcome to any members of the public who may be observing us today. This morning we are meeting in public, and it's the Herefordshire and Worcestershire Integrated Care Board meeting, and I welcome everybody who's observing us and, of course, members of the board who are present today. I think I just particularly wanted to welcome Roy Williams. It's his first meeting today, and so welcome Roy as a primary care member of the board. So a particularly warm welcome to you. We do have some apologies for absence. First of all, from Amanjul Nobbs and Rachel Hardy, both of whom are non-executive members. Paul Walker, I believe, will be joining us around 11:30. And we also have apologies from Healthwatch colleagues who are normally participants of this meeting. So both Christine Price and Simon Adams have given their apologies. I don't believe we have anyone deputising for anyone today. So this is everybody who I'm expecting for the meeting. So I'll move on to declarations of interest, please, in relation to items on the agenda. And I believe a couple of people do want to make some declarations. So Nigel, first of all, please.
Good morning, Krishni. Yes, I'm the chair of the current provider of out of hours services in Herefordshire. So I would just like that noted when that issue is discussed. And obviously I will not take part in those discussions. And I'm also a GP partner and LMC officer. So when we talk about collective action in general practice, then I think that should be noted.
Thank you, Nigel. Duly noted. Thank you very much. And secondly, I believe Will would like to come in as well.
Yeah, I mean, it's probably quicker to go through all of us, but while I'm not a GP partner in Hereford and Worcestershire, I am a GP partner. So normally I manage that conflict of interest because I'm not in Hereford and Worcestershire, but as the collective action is national, it does apply to me too. So just so people are aware, it is in my declarations anyway.
Thank you, Will. And Sarah, I think you'll want to declare similarly to Will, wouldn't you?
Yeah, so mine's just the same as Will, and I'm a member of the LMC in Coventry and Warwickshire.
Thank you, and indeed Roy, of course. Roy.
Yeah, I'm a GP partner as well in Hereford and Worcester. Thanks.
Okay, thank you, Roy. Okay, so declarations in relation to this agenda noted, of course, as colleagues have referenced, there is a declaration of interest register, and it is available for members of the public to view, and we just ask members to keep that updated. So Hannah, I believe we're quorate. I think we've got enough people to constitute a formal meeting, so we can continue with our business. We do have a governance log and a board forward plan, which is available as enclosure 4. I don't believe there are any outstanding actions at the moment, so unless anyone wishes to raise any questions about it, that's just there for our noting, I believe. Okay. So we move on then to the minutes of the previous meeting held on the 15th of May. Are colleagues happy to approve it, or are there any points of accuracy that anyone wishes to raise? Okay, I'll take that as colleagues being satisfied that it is accurate and therefore happy to approve it. Thank you. So we move on then to our patient and public voice section. We did receive a query from a member of the public who is a patient, and for that reason we didn't feel it was appropriate to identify the individual. But Simon, I think you're just going to respond more broadly around the issue that the patient raised.
Yes, I am. Thank you, Christian. We actually had another complaint last night as well, which is also about a patient issue. And just for the board's assurance, we will obtain the necessary consent, and we will investigate that, and we'll go back directly to the individual concerned. So yes, we had a query yesterday which related to the patient's right to choose, particularly if they've already waited more than 18 weeks. And I think it's a really good opportunity to remind ourselves and the public actually listening that if you have been referred for treatment, if you have waited more than 18 weeks, you are perfectly entitled to go back to your GP and to ask for other options to be referred elsewhere, particularly obviously to somebody who can offer that treatment, a provider who can offer that treatment in a shorter time frame. So this particular individual had waited more than 18 weeks for, I think it's some kind of hip treatment at Wye Valley. And our advice is go back to your GP, discuss that, and the GP will have information that can inform a decision about a new referral. So that is quite a good opportunity to remind people. Christy, there were two other parts to the query which I think are also worth airing. So firstly, about compliance with GDPR, which is often at the heart of a lot of this patient-related activity, and something we do take very seriously. So we would always ask for patient consent, specific patient consent, before then taking those details to talk to another provider about their care. And actually, it's helpful that it's mentioned within my report today that we have got, there's a test, if you like, that we do annually, which is the Data Security and Protection Toolkit. We've just completed that and we were fully compliant as an organisation, and that's something the auditors review as well. So that's helpful. And the third part of the query was about the balance between home and office working, and it's just also good to put on the record that the ICB as an employer, we operate a hybrid working policy where we ask our staff to spend the majority of their working week in the office, and we have excellent compliance with that. Actually, we've got a really good office presence. So a useful opportunity, Krishni, whilst not specifically going through the patient detail, but to put on record some information in response to those queries.
And thank you, Simon. And just to confirm again for members of the public, I think an element of this particular inquiry was around the process for getting that additional, the opportunity, and there seemed to be perhaps an expectation that the ICB would facilitate that. Is that? I think that's right, isn't it? So you wanted to be clear that that did need to go back. The individual did need to go back to their GP for that as part of that process.
Yeah, because we wouldn't, the ICB doesn't have the information to hand or the clinical experience to make the right judgments around the right alternative referral route. So absolutely, the process would be to return to the GP and have that discussion.
Yeah, thank you. Russell.
Just because I'm not sure it was entirely clear in Simon's answer, but for members of the public, if your GP then does refer you to a private provider, there is no cost to you. Any sort of medical help that's required, any operations, any aspect of care will be provided free to you, but in that scenario, potentially by the private sector.
Thank you, Russell. So hopefully, if the person who submitted the inquiries is watching us today, that answers the question. But I know, Simon, you've also responded personally to the individual as well, so thank you. And we do encourage questions from the members of the public, broad, particularly questions that I think are policy and commissioning decisions and matters that relate to system issues and how things flow within our system. Of course, individual inquiries we will respond to as complaints on the whole because of issues of GDPR and making sure we protect patient confidentiality as well. Sarah.
I just wonder, Krishni, because this has been raised today, whether we're able just to close the loop on that and make sure that we communicate this back to our GP colleagues, and just so that they're aware of, they may well already be well versed in exactly what to do, but I'd hate that to be a gap that people now turn up to the GP and then the GP is unclear what it is they should do. So if the loop's already complete, that's fine, but if not, it would be really good just to close that today. Thank you.
Thank you,
Yeah.
Sarah. Will?
We were talking about this morning, Sarah, and George, one of my deputies, is going to do some updates to GPs around provider of choice as a whole. So I'll make sure he includes this information in it. And just on Russell's point, it's probably just whether it wouldn't be any private provider, it would probably be private providers who hold an NHS contract.
Okay, thank you, everybody. I think that's probably helpful, and thank you to the patient who gave us the opportunity to respond to that, because as colleagues have said, it's an opportunity really to make everyone aware of the process and reinforce that also to colleagues in primary care. So we'll ask Will if you can follow this up, Will, with the process that you've already agreed to undertake or was planning to undertake. Thank you very much. So we move on to our patient story, and over to you, Kath, for that, please.
Thank you, Chair, and good morning all. Today's patient story has themes of cancer diagnosis, screening and testing, which goes with today's spotlight, which Mary will present later. This theme may trigger personal memories and thoughts of loved ones, and specific support resources will be referenced online, and I will verbally reference at the end of the story today. The story is anonymised and real names are not used. This is the journey of John. John is a 52-year-old male from Worcestershire. John was fit and healthy, regularly attended the gym, and generally considered himself to be in good health. In July last year, John noticed changes to his bowel habits. He felt tired for no reason, and he had stomach pain and bloating. John contacted his GP as he recognised these symptoms as potential signs of bowel cancer. One of John's family members had passed away 5 years previously of bowel cancer. Therefore, John was, in his own words, terrified when he started to display similar symptoms. Bowel cancer is the third most common type of cancer in the UK, and screening is offered currently to everyone aged 54 to 74. This screening programme is being gradually expanded to include everyone aged 50 to 53. John, at the age of 52, fell outside of the screening programme, but his heightened awareness made him realise the need to seek medical advice at the earliest opportunity. John attended his GP surgery. He was understandably very anxious. The GP confirmed with John that he wanted to undertake further tests and arranged for John to have a FIT test. This is the fecal immunochemical test, which is a test that looks for tiny traces of blood in the poo that are too small for the naked eye to see. This test was found to be positive, and the GP then referred John for an urgent colonoscopy. A colonoscopy is a test to check inside the bowels, where a long, thin, flexible tube with a small camera inside it is passed into the bottom. John was referred to the hospital within 2 weeks and described the process of seeing his GP to the initial consultation with the consultant as seamless. On the day of his colonoscopy, John was extremely nervous and emotional about undergoing the procedure. The nursing and medical staff could see he was distressed and took time to sit with him and explain everything that was going to happen. John described the level of care and compassion that he experienced as deeply touching and overwhelming. He particularly wanted to thank the 3 nurses in the procedure room who were brilliant and so friendly and understanding, and he described the immediate aftercare post-procedure as being excellent. Thankfully, the outcome for John was good. He didn't have cancer, and he was given the all clear. He describes how even the results were given to him quickly and efficiently with kindness and compassion. John also explained how his care and treatment didn't just stop following the colonoscopy. He had a post-procedure checkup, which he described as very informative, with just the right level of information being provided. Time was taken to listen to his worries, concerns, and answer all of the questions he had about before, during, and after the procedure. He was also given informative literature to take home to read and digest. John expressed his thanks and deep gratitude to his GP and all staff on duty on the day of his colonoscopy for the kindness, compassion and professionalism that they showed him. His thanks have been passed on to the staff concerned. Thankfully for John, his symptoms did not lead to a diagnosis of cancer. Unfortunately, this is not always the case, as around 392,000 people are diagnosed with cancer in the UK each year. This means that someone in the UK receives a cancer diagnosis every 2 minutes. In Herefordshire and Worcestershire, there were over 5,000 new cancer cases in 21-22, giving us a higher rate of 669 per 100,000 than the England average of 540 per 100,000, with approximately 4,000 referrals each month into the cancer pathway. This constitutes about 24% of all referrals received each month. Over a third of cancer cases are preventable, and people can reduce their risk by not smoking or stopping smoking, maintaining a healthy weight, reducing alcohol intake, being more active, and eating a balanced diet. John's journey through our system, while scary for him, was a positive one in terms of the treatment he received and the outcome for him. However, I think it is important to end the story by highlighting the importance of recognising potential cancer symptoms and being body aware. John had the courage to recognise the changes in his body were not normal for him and contact his GP. As this story highlights, it does not always end with a diagnosis of cancer. But if it is, early detection makes it more treatable and will save lives. Dame Deborah James passed away from bowel cancer in 2022. She spent a lot of her life post-diagnosis raising awareness of bowel cancer and the symptoms. I will leave you with some of Deborah's final words. Check your poo, it could just save your life. And for more information on the signs of cancer, you can visit www.nhs.uk/cancer symptoms, and that will be on our website as well. Thank you. Over to you, Chair.
Apologies. Thank you very much, Kath. Really important experience outlined and positive, a positive one, but important as nevertheless, because it reinforces what's helpful, I think, for patients as well. You know, that the word seamless experience, I think that strikes me always as something that patients value, and the fact that John felt his care was deeply touching, or the way in which he was treated was deeply touching. And excellent, was really positive to hear. Can I invite any other comments or questions relating to this story? Stephen, please.
Yeah, I think stories like this always touch you, and to re-emphasise the importance of getting tested, and just a signal there's some really important changes that are potentially coming as well, in terms of we're involved in potential pilots around lowering the age that you'll receive a test automatically and lowering the sensitivity. So that message of checking everything, and if you do get a test, make sure you use it, send it back. It's really easy, and it lets us pick up on that really quick and get the treatment that you need. So just to re-emphasise that, really. Yeah,
thank you, Stephen. And I think it also, sorry, Russell, would you like to come in as well?
Okay, Krishni. I mean, as a cancer survivor myself, I think it's worth just emphasising to members of the public, you know, if you're anxious about a change in your body, as we've just heard in that patient story, anxiety has very little benefit. Going to get a test has a big benefit. And even if the diagnosis is that you do have cancer, the level of care which the NHS is able to provide, and the third party and the volunteer groups that are around to support people with different types of cancer, means there is a real life after cancer. It's not by any stretch of the imagination necessarily at the end of things. It's just a different chapter. So I would really just endorse the encouragement to go and get tested if you need to. There is just a new chapter of life which we're here to help you work through.
Thank you very much, Russell. If there are no further comments, Kath, please thank John for sharing his story with us. And I think, as I say, it was really positive to hear the feedback he'd given, and really helpful that members of staff were praised, I think, for the service and care that they provided. So thank you. Of course, as Kath explained, that the theme, the spotlight on cancer through this meeting will follow with an item item 10, which Mary will talk us through shortly. But before we get there, we've just got a couple more items, and we'll pick this theme back up and explore it further. So thank you very much. We move on then to the strategic update section, and the report from Simon, please, as Chief Executive Officer.
Thank you, Krishni. So hopefully people have had a chance to read the report. So as usual, just to pick out a couple of headlines. So firstly, the first part of the report covers, we have had our operational and financial plans signed off now for this year. So now our focus is clearly on delivery. The commitments that are made specifically in the plan are summarised in the report, which board members hopefully find sensible. On the second page and third page, you'll see, and this is covered in some of the other reports on the agenda, my summary would be that the performance improvements we saw in many areas in Q4 of last year actually very encouragingly are continuing into Q1 of this year. So on the whole, we have a really positive trend through some of the main areas that are a real priority and focus for us, specifically urgent care, cancer, and elective care, waiting list, backlog reduction. So on the whole, performance is heading in the right direction, which is good to note. I'd also like to draw attention on page 4. I mentioned the impending SEND report into Worcestershire Services for Children with Special Educational Needs and Disabilities. That actually was published on Monday this week, so obviously not when we wrote the report last week, but on Monday this week that report was published. I think it's fair to say a disappointing outcome that does recognise some of the progress made, but also very clearly highlights a lot more work to do in certain areas. For us, from a health side, so specifically focused on some of the waiting times for some key services, community paediatrics, therapy, and some of the assessments. So work to do on our side in particular to match capacity with demand. Demand obviously has changed significantly for some of these services over the last 2 or 3 years. We've now got to go through a process to make sure capacity matches ongoing demand, but also any waiting lists and backlogs that have been built up. Common with lots of our other treatments and procedures, we find the capacity and a means of reducing those. So we've taken a couple of actions already to try and outsource some additional capacity to come and clear a couple of those waiting lists, and there'll be an ongoing process working with Rob Mackey and his team in Worcestershire to try and work out how together we can resolve that ongoing demand and capacity match. So important, I think, that we mention that because the report has been published since we published these board reports. And finally, just to finish on, we have opened our first new dental practice in Herefordshire. So you remember we commissioned 2. One has been opened last month, which is the first new dental provision in Herefordshire since 2007, which I think is quite a stark statistic. And we have a second new dental practice that will open in the autumn, so in the next 2 or 3 months as well in Herefordshire. So lots of work to do to improve dental access. Interestingly, I think that will be one of the things that the new government asked us to work on. We have resources, we have a lot of creative ideas, and actually we want to really make an impact in this area. So it's great that those new facilities are coming online in Herefordshire, and we've got a number of other gaps now we're working on in provision right across the 2 counties that we would look to try and improve. But Krishni, happy to take any questions on those items or anything else in the report.
Thank you very much, Simon. Any comments or questions then for Simon? Tracy, please.
Thank you, Simon. There's a couple of quick questions, if I may. The urgent care piece, the GP contract, I just wondered whether you're anticipating there to be a lot of interest in that contract, and whether there was an opportunity to look at that as part of the upstream, and whether we look at where the service stops and ends vis-a-vis services provided by others in the drive to move services more into the community. And then sorry, I was just checking because Aman had sent through a couple of questions. Krishni, did you want me to pick those up while I'm here? Or do you want to pick those up separately? You're on mute.
Yes, if you want to, but we don't need to pick them all up necessarily.
No, it was
so.
just the first couple I thought were relevant. So she asked, there was an action plan in November around dental, but she asked if there was any sense of priority groups from the dental health equity audit, and it'd be good to understand whether we've captured the hard to reach groups and how. And then the second question she raised was with regard to the self-presenting patients, the audit at the emergency departments, whether that was representative of the whole year, or whether there were any seasonal trends that might affect that.
Yeah, good questions. Thank you, Tracy. So firstly, in terms of the out of hours contracts, so yes, we are anticipating quite a bit of interest in this. One of the reasons that actually we've concluded we will have to go down a procurement route is actually there is quite an active marketplace out there for these types of services. If there wasn't, some of the new rules allow us to take some shortcuts, but actually the fact there is quite an active marketplace, we haven't market tested these services locally for several years now, so we are anticipating a degree of interest. Of course, when we finalise that specification, two things will be of particular importance. One, the ability to have a place-based focus, so we think the needs and the service interfaces will need to be different in Herefordshire than they will be to Worcestershire, so reflection of that. And clearly there's a lot of work going on the whole general practice offer, in hours and out of hours, and all of the additional enhanced services that are offered. So specifically some of the capacity enhancements we're trying to work on. Clearly one of the strategic focuses for us will be trying to make sure as much of that as possible is joined up. I don't think there is a silver bullet that will mean it all gets resolved in one go, but we've got to be on a direction of travel and on a journey where piece by piece we are joining more and more of that up. Quite good question from, I know a man mentioned about the dental health access equity audit, so very much that audit does pick up areas of deprivation and higher need. We will also be looking to prioritise the next round of commissioning new capacity. There'll be a prioritisation around that audit and those core 20+5 key actions. So we're very, we do see that one of our, what we try and do, don't we, with the health inequalities work is we're trying to mainstream it. So it's not work on in its own right, it's work that we apply to every project. And actually this is a really good example of where we have the ability to commission new dental capacity. We've got the desire to reduce some health inequalities as one of the main drivers as to where we choose next to take that work, which is really important. And your final point around the walk-in audit, another good question. So we feel it is fairly representative actually, because there isn't actually huge variation in demand through the year now. The story of the last 3 or 4 years really has been a pretty consistent in demand trend. There are the odd spike during the winter period when we have flu or COVID, but when you look at the numbers, actually the numbers are pretty consistent. There certainly isn't a summer drop-off in A&E departments where there are much less people. The levels of demand are very consistent actually throughout the year. So we're doing that walk-in audit. It's really important to understand specifically what efforts patients have made to access other services. And actually we usually find some patients haven't tried to access a GP appointment or community services or wherever, they've just gone straight to A&E. So there's always a big kind of communications, information, public awareness element to this, but actually the audit can really inform some quite bespoke and specific communications and messaging work around that.
Thank
Is that
you.
helpful, Tracy? Answered
Yes.
all the questions, I think. Thank you.
Thank you.
David, please.
Thanks, Krishni. Mine was not so much a question, more a kind of welcoming, because Simon's put some really good news into different parts of this report. I mean, the fact we have agreed a plan with NHSE, both financial and target, and there's a real feeling of improvement coming through this, that we actually are making progress. Of course, challenges remain, but we really are making progress. And I think that's something we should all be really proud of. And I kind of pull out, you mentioned before, the dental provision in Hereford. That's fantastic news, but also something which I think underpins what we're talking about, which is it showed in the shared program director for the Work Well program. I know it's only a tiny item, but actually it's cooperation across different parts of the system working really well. So I wanted to welcome and congratulate the team on that.
Thank you, David. That's some really important positive points to pull out there. So really good to highlight those as well. Simon, a couple of things from me. One was just really thinking ahead to the year, and might need Hannah's input on this as well. But I was looking at our sort of plan commitments, and now that they're there and very clearly laid out in your report, I'm wondering whether there are particular areas within that we think might be more significant risks that for the board that we'd like to spotlight through the course of the year. And I just wondered whether colleagues might want to comment on that, because I think, Hannah, we've probably got the opportunity to plan ahead a little bit at this point to say, well, what would we like to really come back and explore of some of these opportunities in a bit more detail. A good example might be dementia diagnosis. I know it's had some focus at the Mental Health Collaborative and more than once, but it may be at some point later in the year, because we know this is a challenging one and it's a system-wide issue for us. I wonder whether it's one of those areas that warrant a spotlight. So just any thoughts from anybody really on that, areas that we might want to, as a board, come back to over the course of the next few board meetings. So Simon first, and then I'll come on to Sarah and Russell.
Yeah, just a couple of things really. And one, yes, the mental health performance, specifically the dementia diagnosis. I think there is risk. I think we have the ability to hit our trajectory, which of course isn't quite the national standard, but I think we have the ability to get there, but there's a lot of work to do and there's a long way to go. It also feels like we're trying a different approach, and John Dever-Priam, who's the Chief Medical Officer for Herefordshire and Worcestershire Health and Care Trust, he's going to lead this for us. So we're trying a different approach, but I do think it's something the board need to be aware of and support and to really own. The second thing I would say in relation to the plan, Krishni, I think we have a deliverable financial plan. I think it's going to be a really hard work, but I do think it is genuinely deliverable, and we want to focus on that. But there's a second element, which is we need to also be working on the medium and longer term financial plan. We are operating with a deficit, which means we spend more than we are given. We have had support for that this year, but actually we need to be looking to make incremental steps in the right direction with that over the next 2 or 3 to 4 years maybe. And I think that, again, the board need to be part of that conversation. We should be having that in public around the types of productivity improvements, efficiency, service consolidation, sustainability, viability. Those types of things are going to need to be really important. So both of those will feature, I'm sure, on our forward plan.
Thank you, Simon. Sarah.
Yeah, thank you. I mean, I agree that a real risk in terms of reaching a target is the dementia diagnosis rate, but I think I'd probably value a conversation about, if we're going to talk about that at board, then that is one very specific element of a whole wider dementia strategy. So from previous conversations at the Mental Health Collaborative, I think we would need to be really clear about what it was we were bringing here, which element. And I do think that it would be a useful conversation to have as to what are we, as an integrated care board, more interested in terms of dementia services as a whole versus the dementia diagnosis pathway. And I absolutely apologise. I will put my headphones on. I can see people smiling. My son is home from university and music's in the background.
Thanks, Sarah. Yes, unfortunately it did, I think, overshadow your comment there, so that might be helpful. Thank you. Okay, and Russell, please.
Well, I think the first thing to say is the music in the background, Sarah, was an awful lot better than when my son was trying to learn the violin. Just a few points, and I agree with colleagues. I think in terms of Simon's important emphasis on the medium term, I'd make just a couple observations. The first is our financial deficit as a system is driven by the providers, the acute providers, and therefore that anything that can help the acute providers get into a better position is obviously something we need to make sure we're prioritising. The reference cost data came out for the NHS last week, and as I recall, Worcester was at 101, 100 being the number one would expect on average. So Worcestershire was at 101 and Wye Valley was at 106. Now 106 for Wye Valley is recognised as a rurality issue, and given that Stephen, Glenn and I know the enormous opportunities at Worcestershire in terms of driving improvement, 101 I think says the NHS has a real opportunity on productivity generally. So I think by us working together as system partners, effective system partners, we can make an awful lot of improvement on our financial outlook over the medium term. There are two things which are affecting the acute providers in particular on the risk register side. The first is the extraordinary and unprecedented demand we're still seeing into the A&Es. The acutes are funded into their A&Es at its simplest on a block contract. Therefore, we take a big financial hit when we see the levels of demand coming into the A&Es. So working with system partners to get that demand, which is unnecessary, into an acute accident and emergency department going elsewhere, is time well spent. The second is discharges, where we still have a number of medically fit for discharge patients in the most expensive care setting in the system, which is the acute. Working with colleagues in particular, helping to find new and innovative solutions to support our local authority and county council colleagues with their social care funding challenges, so that we can get medically fit for discharge numbers down, which allows us to free up beds, which allows flow to work better, I think is one of the things, again, we need to make sure is getting the right profile in these discussions. So system partners working effectively together is going to be the cornerstone of us being able to drive the financial performance of this system in the way we should be capable of. Thank you.
Thank you, Russell. Vicky?
Thank you, Krishna. It was just a response to your question about what points of interest for the board in the future and for this year. And I think, Hannah, we've already got it, but to Simon's point about the SEND report and the disappointment about that, I note in the report that it's requiring a particular place-based action plan response, and it would just be good from an ICB point of view, whilst we've looked at children's services before, just to be able to look particularly at this and the place-based responses to this report and understand that as an ICB board. So if we've got it on the plan already, great, but if we haven't, it would be good as a board to understand the place-based response.
Thank you, Vicky. Hannah, I think that might be on our plan already, having had a look briefly at the forward plan, but perhaps you can confirm.
Yes, thank you. So with regards to children, so we do have a dedicated session on the development sort of board forward planner. So in October, we'll be talking about children a lot, and then I suggest we can then bring it to a public board deep dive later on in the year. And I also wanted to flag that at the next meeting in September, we are spotlighting learning disabilities and autism. So that is one of the areas that has been flagged in the operating plan commitments. So.
Thank you, Hannah. So obviously building on the things that we'd already planned on, that just probably some areas then to think about, probably need to take, well, certainly need to take into account Sarah's comments about if we're doing dementia, you know, are we talking about dementia diagnosis or the sort of more broader dementia strategy, or mental health more broadly. So those are things we can take away and have a look at, but it was an interesting opportunity, I think, just to explore where the board would wish to focus on some of these things in the coming year. And indeed, so the to have turned off, so I just wanted to mention that in case that has, I believe it's come back on now, so that's probably working again, so thank you very much. Okay, so if there are no further questions or comments on Simon's report, I think, Simon, there was nothing to approve, if I remember this time. It's just asking us to note the report and the update that Simon has provided. And thank you to colleagues. You know, there's always a lot of effort into not just writing the report, but actually in terms of the things that are reflected in the report is, you know, it's a summary for the efforts on the work being undertaken. So we move on then to the next item on our agenda, which is the committee escalation assurance report. So Hannah, I will invite you to come in first and then ask any chairs who wish to make a comment on their assurance reports to raise their hands, please. So Hannah.
Thank you. So it has been a really busy period in terms of committee meetings, as you can see from the report. So it's probably longer than you are normally used to. I would say that we are now really truly in the swing of things with our committees that are really well embedded, really efficient and effective, and we do regularly review the efficiency and effectiveness of our committees, both annually and also at the end of each meeting. So there's nothing specifically to highlight other than the content of each of the committees' summaries.
Thank you, Hannah. So I'm guessing that none of the committee chairs particularly want to come in to say anything about their reports, which is absolutely fine. Are there any questions or comments from colleagues before we receive and note the assurance? I'll take the opportunity, if I may, just to mention a couple of things. I was interested to see the Mental Health Collaborative investment decision and one around an app called Luminova, I think it was, which sounded really interesting. And I just wondered, Sarah, whether there's a plan to sort of, is that something that is being used in other places, and are we looking to evaluate the effectiveness of that kind of technology in supporting young people? I think it was intended as to support young people with mental health difficulties.
Yeah, it looks really promising. It looks as if access to for lots of young people, it is being used in other places. Different levels of uptake depends on different parts of the country, but we're really hopeful that actually we'll have a really high uptake. And yes, there is evaluation in place as well, and there will be a public facing and primary care sort of information so that people are aware of it and aware of all the good things that it can hopefully do to help people with their mental health at quite an early stage. But sorry, Robert's the expert. Thanks, Sarah. I wasn't sure who I would address my question to. So Robert, do you want to come in?
Yeah, just to add a little bit more, as Sarah's already said, actually, it's part of a suite of interventions we have to increase access for young people, support with their mental health and well-being. Probably key bits just to draw out. Yes, it is being used in quite a few other places around the country. It is NICE approved. It targets a specific kind of age range, which is the not the older young adults, if I could put it that way, but sort of in between. And it's 18 months so that we've got a proper chance to really see the impact. But yeah, some really good discussions about that. So I think we're quite excited about how that may help with the overall offer.
Yeah, and you know, it's great to highlight these sorts of opportunities and decisions that we've taken, because, you know, digital solutions are very appropriate for some cohorts, I think, because the take-up can be more positive, and great to hear that, you know, these sort of innovations are in place. So thank you. Okay, if there's no questions about that, I also just wanted to raise, Will, this might be one for you. There was reference to a long-term condition strategy and something that we'd, I think, signed off possibly at strategic commissioning. I thought it was great that we'd done that. I was a bit concerned about strategies that they don't just sit on a shelf somewhere as a document that we've approved. So I wondered what the plan is for taking that forward and making that a sort of reality in terms of how we work.
So the long-term condition strategy it's a fantastic piece of work that's gone through quite a significant piece of engagement and planning. It links into. It's one of those things that it really exemplifies how we work as a system, and it overlaps into secondary care, how we look at secondary care services, how we bring those into the community, and that kind of concept of left shifting, and also really embeds into the concepts of fuller and neighbourhood working. So it's not going to be something that sits on a shelf, and I think we can be fairly assured about that. It's a key piece of work that thinks about how we provide care fundamentally, pretty much as a system, over the next sort of 5 years, and how we shape that around the needs of our population in place and close to their home. So it really wraps around them. So it's a very core part of what we want to deliver.
Brilliant.
So yeah, I don't think there's any risk of it sitting on a shelf.
That's good to hear. Well, thank you, and really, you know, again, good to hear about an important system piece of work that has had that kind of level of engagement and contribution to it, and look forward to seeing the sort of outcomes of these strategies over the years, because these obviously are very much long-term, I guess, visions, aren't they? So thank you. So we are really noting the suite of assurance reports we've received from the committees, and really, obviously, from a board perspective, that the reports are there for us to gain assurance that the committees are discharging their responsibilities on our behalf. So thank you to committee chairs and members who've contributed. We move on then to the spotlight on cancer, which we referenced earlier, which is item 10. And Mary, this is over to you then.
Thank you, Chair. Thank you. Board members will all be very well aware that the last few years, the entire NHS, and indeed our ICS particularly, has spent a lot of time recovering from COVID in the world of cancer, and really focused on the key cancer targets and making improvements, because we were in a challenge position. I think it's really pleasing, as just on the theme of earlier, you know, that in particularly the last 6 months, I'd say we've seen a stabilisation of the cancer position. There's still a lot more to do from a cancer performance point of view, but we're now much clearer and working much more together as a system on the improvements that we need to make on the key cancer targets. But this report is broader than that. This report covers the cancer prevention and awareness raising that we need to do, the screening, diagnosis and treatment, and some of the aftercare services. And I would like to touch on some of the health inequality issues as well that drive some of the cancer position that we have. So I won't go over what Kath's already rehearsed in her patient story, but I think it's key to notice that there is an increase in cancer rates. It has been for the last 20 years, and we're predicting another 2% increase in the next 15 years. So matching demand and capacity in NHS services is an ongoing, consistent challenge for us. For our ICS, we do have a higher than national average new cancer cases. We haven't had much opportunity to look at that in great detail over the last couple of years for the recovery reasons, but we will be spending much more time now as an ICS trying to understand the reasons for that and understand why our referral rates are lower than the national average as well, whilst our conversion rates for cancer, those patients that do eventually get diagnosed with the cancer, is slightly higher than the national rate as well. So we've asked our elective cancer diagnostic board to look into this in some detail with public health to understand, is there anything we need to be concerned about or not behind that, or is that something that is part of this area's demography? So we'll keep board members informed of that going forward. Obviously, as we said earlier, prevention is an opportunity. Screening is the best way to get to earlier diagnosis of cancer. And our ICS approach going forward is going to revert the stage 3 and 4 cancer diagnosis. That's people diagnosed with cancer at a later stage, to stage 1 and 2, where if treatments can be started that are more beneficial to long-term outcomes. So there's a national target that, 75% stage 1 and 2 by 2028. And a lot of this paper is about how we are trying to do that and how we're intending to increase our actions to get that stage 1 and 2 cancer diagnosis within our ICS. So Kath has outlined the healthy lifestyles that people need to live, and through our health promotion work, we will continue to do that with our populations and our communities. But I'd like to pick up 3 of the things that we're doing currently. So we're obviously engaging with GP practices through the earlier cancer diagnosis DES, the directly enhanced services, focusing on improved uptake of cervical and bowel screening, and the proactive opportunity assessment of patients at a higher risk of developing cancer. So we focused in the last year on prostate cancer with men who are having a higher risk of developing prostate cancer. We're invited for a discussion and potential testing. And we're going through the high rate cancers and trying to work with primary care over the next few years to improve that screening. I think it's already been mentioned by Stephen and Kath. So the FIT testing, we are one of the regional leaders on FIT testing. So I think it's really welcome that primary care have embraced this so well across our ICS. So we have a high rate of FIT testing, getting those patients early into diagnosis and only sending them on for treatment when needed. And we've just put in for a bid to lower the rates that we do send patients off for FIT test for colonoscopy, aiming at getting a younger population and people who are earlier in their diagnosis through our systems. We're on the NHS Galleria trial. It's a research trial using a blood test to detect early cancers. I was hoping to have the results, the national trial evaluation results, to be able to give to you, but that's still not been publicised. But we've been part of that trial, and we look forward to the outcomes of that to see what that means for early detection going forward. So that's some of the areas we're currently involved in, and you can see the others in the paper. But the things we're going to do next to try and again get us to that stage 1 and 2 diagnosis, we're rolling out the non-specific symptoms pathway. This is where patients come forward with non-specific symptom, vague symptoms. It's difficult to put them into a specific cancer pathway. So we've got a small team already in Hereford, and we're just trying to get this started in Worcestershire for that GPs can refer to have a general diagnosis and a general assessment of the patient, and then get them into the right cancer pathway if appropriate. And then targeted lung health checks. I mean, it's interesting, lung is one of our very late stage presentations for cancer, particularly in patients with mental health, learning disabilities, and some of our ethnic groups as well. So the targeted lung health checks, we want to screen patients at risk of developing lung cancer, leading to that earlier diagnosis. So our aim is to start screening in Herefordshire by the end of next year and Worcestershire during 25-26. We will seek to see if we can bring that forward, but that is part of a national programme that we want to make sure is implemented across our ICS. And then we want to be implementing liver surveillance for patients with cirrhosis and advanced fibrosis or hepatitis or liver problems in general to support early identification of liver cancer. Again, these are key at-risk factors that come before liver cancer, so we want to start liver surveillance for those. So there's a programme that our Elective Cancer Diagnostic Board will oversee of all of these actions, all aiming to get us to that stage 1 and 2 diagnosis. I think, our hard to reach groups are going to be the challenge for us. That's the learning disabilities, mental health groups, some of our ethnic groups and screening, and some of our younger age groups. So using our outreach facilities, our work in district collaboratives, our work in schools, we're aiming to raise the awareness of the benefits of early screening and reduce the burden of late stage diagnosis. So that's really our approach to the prevention. You can see on page 4 our screening update. We have recovered completely now. There's the national screening programmes for cancer, and we're doing slightly better than the national benchmarking, and it's really pleasing to see that is back on an even keel now for our ICS as well. So moving us on to page 5, the cancer diagnosis and treatment. So you can see the rise in demand, and as I said before, this is a real challenge to our ICS for matching that demand and capacity. And I think it's credit to our 2 trusts at the moment that they've maintained and improved the position given the amount of referrals that increased referrals they have seen. And you can see our largest number of referrals on the breast pathway, colorectal, skin, gynecology and urology, and that's a 19.2% increase since 2021-22, which is again quite significant. But we are doing well. So our 28-day faster diagnosis standard, this is the slightly new standard for cancer. We have in April we were at 68% within 28 days, and that has improved to just under 77% non-validated at the end of the June. And that gets us to the end of year standard. So if we can maintain that over the winter period, great for patients, but we'll be maintaining our standard as well. 62 days, those waiting treatment at 62 days, very important for patients that are diagnosed with cancer. So in March, we had 39% fewer patients waiting over 62 days than the previous April, significant reduction and a significant improvements in some of our really hard to challenged specialties like urology, colorectal and lung. We're currently at about 62% against the 70% standard for 62-day cancer. So there is more work to do on the 62-day standard, which we'll maintain over the winter as well to aim to reach that standard. To help to do that across the ICS, we're looking at the best practice time pathways. This is nationally driven. How you should run a cancer pathway, how you should deliver it. Our analysis is out of the roughly 15 cancer pathways, we're largely delivering 10 of those in best practice format. We've got 5 pathways that we really need to focus on that are outlined in the report, and that is largely the misalignment of demand and capacity, but some improvements that we need to make to process as well. So that we have very good and strong governance in place to make sure we're analysing those pathways and making the improvements, and a lot of support from the Cancer Alliance regionally as well to give us some resource and some tools to help us. We're aiming to reduce variation across the cancer pathways in the same way, and we've got GIRF getting it right first time for cancer now as well. So we're implementing that across the pathways and working with the clinicians to look at how cancer pathways are delivered in other areas and bring that learning into our area as well. Personally, I think one of the biggest risks, or one of the things that keeps me awake, is the capacity in diagnostic services. With that demand, our diagnostic services are under significant pressure, and because our strategy of trying to get earlier diagnosis, earlier screening, we're constantly putting pressure on diagnostic services and oncology services post-treatment, post-cancer. So we are working again across the ICS with the region on how can we increase the capacity in our diagnostic services to meet the demand going forward. And that's a critical aspect for us in the ICS. Workforce planning is a key risk for us. A lot of these pathways need very specialised staff requiring competencies to manage the increased demand. Again, a national problem, not specific to our area. Aiming to find those staff is a challenge at the moment, but through our workforce planning approach and working with the region and the Cancer Alliance, we're seeking innovative solutions to those workforce challenges across the ICS. So that's an overview of our very complex cancer position across our ICS, a much improved position from when I sat here, I think 6 months ago, talking to board. An ability now for the ICS to focus on more of the prevention, understanding our intelligence in a much clearer way than we have done previously, but still a challenge we need to meet going forward in demand and capacity. I'm happy to take any questions. Appreciate it.
Thank you, Mary. First question from Vicky, please.
Thank you, Mary, and it's great to see some of those improvements across all those cancer pathways, but obviously acknowledge all of the challenges that we've got going forward. My question was particularly on the awareness and the prevention. So as a system, are we content that we've got enough data to know where some of those hard to reach groups, whatever the reasons are, that we've got the data so we can agree how we improve awareness and the prevention?
We've got, I mean, I might bring David in on this, but we've got some data that backs up some of our findings. So particularly for learning disabilities, an example, we have 6% lower participation in the bowel screening programme, people with learning disabilities and autism, and the LEDA reviews have shown us some of the deaths in people with learning disabilities. It has been very late presentation cancer. Some of that we have in our screening services. We know that women from a Pakistani and Bangladeshi background are very poor at accessing our screening services. So there's some targeted work we need to do with those groups to get them to understand the benefits of accessing these services. But I'm sure there's always more intelligence and data that we could need to back up where we're targeting our prevention.
Thank you, Mary. And I can see David wants to come in on that. I'm assuming, David, so shall I just bring you in so we can follow that theme?
Yeah, sure. Thanks, Christian. I won't add to what Mary's said, but I agree with all of the points she raised. It's just specifically on the Pakistani and Bangladeshi women. We've recently won some funding to develop a community connector to work with that community, and that service will be setting up soon. So that's specific on that particular area where we're demonstrating we found poor access and we've done something about it.
Great, thank you, David. Thank you, and thanks, Vicky, for the question. It was one of the areas I think I was going to explore as well, so that's really helpful. Thank you. Nigel, please.
Thank you, Krishna. I was going to raise the point about those underserved groups as well. So I think thank you, Vicky, for raising that. It's been answered. The second point was about the lung cancer screening, and quite rightly, I think GPs have some concern that this is going to put a lot of strain on diagnostic services, and that the fact that we're not going to be able to get timely investigation of people who have symptoms. So I guess some assurance around that would be useful. And the second is the management of the sort of incidental findings. When this has been implemented, there are quite a lot of non-cancer findings which generate quite a lot of additional work, and that processes are in place to manage that without directly affecting existing services.
I'm happy to come in there, Nigel, Krishna, if that's okay. So, and this is why the demand and capacity analysis of diagnostics is really important at the moment, and why the targeted lung checks we can't do very quickly. A lot of your colleagues across the region have raised exactly the same issues, Nigel, through the Cancer Alliance. So we'll only implement this when we know we've got the right capacity to deliver this, and it doesn't affect symptomatic patients, because that is definitely at risk. The incidental findings have come up in the pilot sites as a bigger issue, I'm told, than it was anticipated, and they've had to create different pathways for those patients. So again, we're well aware of that. So we will, through the Elected Cancer Diagnostic Board, make sure that we sign off a pathway that is able to manage that situation as well. But it is going to need more capacity and workforce, which is going to be the challenge, definitely.
Does that answer your question for now, Nigel? Appreciate that there's obviously work to be done in this area, isn't there?
Yeah, no, I think that's probably as much as we can do at this moment, but it would be useful for the board to be updated with progress as we move forward.
Yeah.
And Mary, if we can do that through, obviously you've got your opportunity through the normal quality report, haven't you, through so the performance report, that we can keep people updated. Tracy.
Thank you, Chair. Couple of quick questions. The first is with regard to the referral rates and then the conversion rates. If we've got the lowest referral rates but the highest conversion rates, I wondered whether we'd got a higher incidence of stage 3 and stage 4 than the national average. And that might not be something you have to hand, but that sort of correlated to me. And then the other thing was, it's great news that we have such low conversion rates nationally, but I did wonder about all those other patients that are being referred in who don't have cancer. What then happens to them? Presumably they go back to their GPs, obviously, but is there some sort of analysis that we're doing to understand what else might be wrong with them?
Yeah, so on the first point, this is I've asked the Elective Cancer Diagnostic Board to analyse all of this information because it doesn't quite all add up together. Some of our data around stage 3 and stage 4 cancer, or staging in general of the cancers, we want to make sure is correct, because we're not 100% sure that's correct at the moment. And it's because we've now got some time to look at this in detail. I can bring back, once the analysis has been done by that board, we just wanted to highlight today, this is an issue that we found and we want to do some more work on it. It could be a positive thing, it could be something that we need to do work on. We just need to analyse it further from through our governance processes, and we need to get the clinicians together, I think, to support that discussion, because overall we're seen as positive by the region in cancer, but this is the first time these numbers have come out in this slightly concerning way, so we'll analyse it further and come back to you on that. Okay. And if patients aren't seen and they're not cancer diagnosis, they'll be referred. The GP, if they have further symptoms, they will be seen by the GP, or if the consultant at the hospital believes it's another specialty, they will refer direct to the consultant at the hospital.
Okay, that's all right, Tracy?
Yeah, I just wondered whether there was any analysis done of the non-positives to see if there's any patterns in that. That was all, but
well, we are not that I'm aware of at the moment. I can find out. Not that I'm aware that we've had a lot of chance to have a look at the non-diagnosed patients.
Thank you.
So Mary, I think it sounds like there's a bit of work to be done on the data, isn't there, just to understand what it's really telling us and the validation, if you like, if I can use that word, of its sort of accuracy, etc. So difficult. There were yes. I mean, I was reading it and thinking, I'm not sure whether it's telling me whether this is positive. I think it sounds positive, but is it? And it sounds like we just need to be sure that we've got the right data to draw some conclusions. Mary, just one final question from me, and I think you've answered it already, but just to be clear, I think the one thing you highlighted very clearly as something that particularly worries you was the capacity for diagnostic services, or the diagnostic element of the pathway. Can just to help us all be really clear, what are the key barriers to us sort of being able to improve that capacity? Is it workforce primarily, or are there other issues that we need to be addressing?
Okay, thank you. Thanks, Chair. So on each cancer pathway, we're looking at the diagnostics requirements at the moment, as per the national best practice, and trying to project forward with increase of demand. It's twofold, and some of the providers might want to come in. It's getting the workforce, because of the national workforce issues around specialist services, and the resources that we need to buy new, for example, MRI kits, CT scanners, all of those sort of things. It's an ongoing challenge, has been for years in the NHS, but it's an ongoing challenge to do that. We have had, it's been very helpful, some national monies in the last couple of years to do community diagnostic centres, which I think without them we would be in a very difficult position at the moment. But we don't believe at the moment that's going to be enough to meet the demand going forward. So, there is talk of a national diagnostic strategy refresh, and there's new diagnostics coming on all the time, but it's mainly workforce and resource that are the key barriers to this.
Okay, thank you. And particularly, I mean, workforce obviously is something we'll be working on, and I'm sure every, and under all our fragile services framework and everything else, we've been obviously working actively on specific workforce challenges. I'm guessing some of the more equipment resources type challenges because of limits on capital, that's more less within our control.
Yeah, I mean, yeah, the requirements for capital are significant, and I think will be, and as if Mark wants to come in over the next few years, and we're not clear of the position on the capital.
Okay, Mark.
Just picking up on the capital, Chair. So we know capital is constrained. We are doing some work at the moment on what's called an infrastructure plan. So we're looking ahead for the next few years on what capital requirements are, and that does include equipment in there as well. So there's a first submission going into NHS England by the end of this month, and that's been co-produced with each of the trusts. And then we'll be looking at how we start to prioritise limited capital resources in terms of how we target some of the challenged areas, and that will include some of the cancer specialties as well.
Okay, Mark, thank you very much. I think that was referenced in Simon's paper, if I remember, so that's helpful to sort of close the loop on that as well. So thank you, Mark, for the update. If there are no further questions or comments for Mary, thank you, Mary, for that report. I think really helpful to get an update, recognise all the work, and thank you to colleagues. I know there's been a huge amount of effort to improve the position on this. Still clearly challenges ahead and work to do, but you know, if we can capitalise on the progress we've made, it does sound more encouraging than it certainly was 6 months ago. So thank you very much, everybody. Okay, well, I reckon we have sped along at some rate. It must be summer, the effect of summer on board members, that everyone's wanting to be very efficient with our time this morning. So I suggest we take our break now, which is a little bit early, and we probably will finish a little bit earlier today than we had perhaps originally planned, but we will see. It depends on whether any level of questions and issues we discuss later. But I suggest we take a short break now and reconvene at let's say 11 o'clock. Because I think that's probably sensible to take about a 15-minute break. And if colleagues can just turn off their camera and microphone during the break, obviously, because the board meeting is still streaming. Thank you. just give everyone a minute or so just to make sure we're all back, and we'll hand over to Mary at that point. Okay, I'll make it 11 o'clock, so we'll restart the rest of our agenda. And the first item now we're going to start with is item 11, which is the System Quality and Delivery Report. So it's back to you, Mary.
Okay, thank you, Chair and colleagues. So this report, obviously, as usual, provides an overview of the Quality Resources and Delivery Committee meeting that's been held recently, and I'd just like to pick out some key aspects. So urgent and emergency care, I think it's really pleasing to note the improvements. We've had a look back and the improvements that we've made over the last sort of 6 months. A 17% improvement in ambulance category 2 response time, and our ambulance handover breaches over 1 hour, which was a real concern for us, have fallen again for the 4th consecutive month. And the volume of ambulance hours lost because of delays in handover has decreased by 56% in the last 5 months. We do still have some challenges, though, largely around achieving our operating plan targets. So the challenged areas are the emergency access standard, those seen, treated and discharged within 4 hours. It's 78% target by the end of the financial year. And one of the reasons, linking back to the first report, we're doing this walk-in audit to understand why patients are walking into the ED in increased numbers. Our time spent in the emergency department, greater than 12 hours, it needs to improve, as does our length of stay over 14 days. We're outliers in both of those areas. So how are we handling that? So we have just launched the second part of our campaign to staff initially, the Reducing Long Stay campaign. So we'll be working through this afternoon in the Urgent Care Board, the progress being made this week to launch this campaign to staff of the benefits of discharging early to patients and the risks of keeping them in hospital too long. And then we'll share that with the board once we've got the feedback from staff from that first part of the campaign. And then we intend to do the public part of the facing part of the campaign shortly as well. Working on the emergency access standard, I'm aware there's going to be a lot of focus on the walk-ins and the performance around walk-ins that we need to improve as a system, but our urgent care board will be dealing with those aspects. But it is really pleasing to see the improvements that we've had so far. And on page 3 of the report, you can see from both trusts the quality aspects, CQC feedback, and some of the actions being taken by the trusts in response to that. In addition to those quality aspects, there's been a national letter as a response to the media around care and support in ED departments, and the television programme that was aired recently, asking that all boards take note of the learning from the particular hospital that was involved and what we're doing to assure ourselves of quality standards. So we'll be just determining how we do that as an ICB board, and we'll be getting assurance from each of the provider boards about how that's being taken through the process, and you'll be hearing more about that in the coming months. But overall, an improving picture that we're aiming to maintain over winter this year as well. The next aspect from the report I'd like to pick out is elective care. Focus on reducing waits to 65 weeks by the end of September. Again, another operating plan target. We have got some level of risk in that in the system. The target is 0. Again, around demand and capacity and some key pathways in elective care. And we are looking at how we can, in early September after the holidays, enhance our capacity to see how low we can get that number against our target. Enhancing productivity is one of the main aspects that's being driven nationally in elective care now, around theatres, use of outpatients and the diagnostic elements. And we are seeing again some increased improvement in our getting it right first time, our GIRF metrics. Aware this has taken a couple of years to come to fruition, but the GIRF metrics have been very, very well embedded in our system now. And indeed, I went to the Tim Briggs meeting last week, and Kidderminster was mentioned as an area of good practice around using the hub for children's, the elective hub for children's services. But still, we have still got some more improvements to make on productivity across our system. And pleasingly, the elective surgical hub should be open now, Jane. I believe it opened this month, starting working, which is good. This is extra capacity. So we now have one in Worcestershire, one in Herefordshire, extra elective capacity to help us to recover our elective position. Underlying this, one of the main aspects we're tracking through is the patients working over 52 weeks and indeed 18 weeks, and that's looking a more positive position. We're still working at 52 weeks and 18 weeks in some specialties, so that is looking positive as well. I believe we've covered many of the other aspects already in the paper in other reports today, but just pleasing to note the Worcester Acute Maternity Safety Support Plan, that sufficient progress has now been made, that they meet the criteria to exit the maternity support plan and be on regular monitoring, which is a real achievement over the last few years. So I think it's well done to all the staff in that system. And finally, 5 new risks. You can see the QRD committee received assurance on the risks, and we've added 5 new risks to our system, mainly around some of the mental health risks that we talked about earlier, and the children's risks as well that we in our system. So that's an overview of the QRD. Happy to take any questions on any aspects of the paper.
David, please.
Thanks, Krishni, and thanks, Mary, for the paper. And again, some kind of good news there and some good improvements going through. A question, we talked a lot over the last few months about the Home Before Lunch or Home for Lunch campaign. Can you let us know, is that still going? Is it showing an improvement in terms of length of stay?
Yeah, thank you. Yeah, so the first campaign, Home for Lunch campaign, it is still running. It is still working with staff and patients. We're having a variable response to it in outcomes, very much dependent on day of the week some days, and certain holiday weeks. We seem to have an issue with it, so we do need to continue to drive the Home Before Lunch campaign. But this second part of the campaign is the reducing length of stay, which does tie into the Home Before Lunch campaign. So we want to really, improve that situation for overall getting patients out of hospital as quickly as possible. It does go back to what Russell said earlier, though, having the capacity in the system to manage the particularly complex patients. But we largely do have a good amount of capacity. It's the processing that we are working in both places, well, particularly in Worcestershire, to make improvements in the process of patients out of the acute. Getting families as well on board with getting patients home as quickly as possible is a key challenge for us. So this is why we're launching these campaigns at the moment.
Thank you.
Thank you, David. Vicky, please.
Thank you, Krishni. Mary, perhaps a question for Kath more than yourself, but the great news about the maternity safety support plan, but I'd understood that through LM&S it had come out of that support plan a few months ago. Is it that the regional recommendation to come out of that had to go to national first before that became official? Is that the way of the world?
Do you want me to come in there? Yeah, absolutely. That's absolutely correct, Becky. Obviously, you'll have seen the tracking through from this right the way from there. So we had a regional recommendation, then have to go to national. So it is now fully exited. Obviously, there are a few things still left, as you're aware, and the LM&S is managing and monitoring those, and we will get updates to that to the QRD committee.
That's great. Thank you, Kath.
Thank you very much. Jane, please.
Yes, thanks. It's a question really on the section of the report on digital, and probably for Katie. I know Katie had only just taken responsibility for digital, but it does seem that this is a massive opportunity for system productivity. and it feels a little bit in the comment that there's almost a bit of a plan for a plan, and I'm keen to understand how we're going to get to decision point on what our system priorities are for investment in digital, because it does feel there's a big opportunity for us.
I completely agree with that, Jane. So we have brought together all the trust strategies across the system. We're looking at the strategy for primary care, and we're adding those all up together and looking at our system opportunities exactly as you describe. We're obviously waiting to see what happens now with the government and the capital funding, and looking at where we can do some of those interconnectivity pieces around data flowing with the patient. We've got a strategy that we want to bring to you, but I will take you through that in a development session in the next couple of months. And then, yes, exactly as you described, we'd like to have an agreed way forward that we've all signed up to, where we can put our funding.
Thank you, Katie. Thank you, Jane, for that question. Yeah, so it's very clearly on our sort of coming up soon plan, isn't it? I know we've been talking. I know Hannah indicated, and Katie, I think you indicated as well, that it would be a development session that we'll be going through together. Because conscious, it's something that we've not been perhaps discussing as much as we would all like, for various reasons that board members will probably be aware of. But great that Katie's taking a leadership role on it, which is great, and we look forward to receiving that. And clearly it needs to attune to the fact that, you know, the new government has expressed, you know, identified digital, I think, as, to be fair, as the previous government as well, as sort of digital solutions to productivity, etc. And patient experience as being key, really. So it is important for us to get on the front foot. So look forward to having that discussion. Russell?
I think it's just worth for a second, without patting ourselves too enthusiastically on the back, but patting ourselves on the back a little bit, how improved the system working is, partner working is this year compared to this time last year. And I think the sort of areas of improvement Mary's been pointing to, I think as a system we can assure members of the public who are watching in, we are, I think, starting to make real progress on working effectively as system partners, helping one another, learning from one another, sharing best practice, and improving a number of the operational, and as Mark will come on to, financial metrics by which we're measured.
Thank you, Russell. I think it's a really important point, and certainly as colleagues who were involved in the regional quality, the quarterly system review meeting, I was struck by how many things we reported to the region we were sort of really working on together, and it's not just on operational performance. I seem to recall, I think one of the areas was infection prevention and control, Kath highlighted, and we've talked about, you know, the long-term condition strategy. We've talked about a number of areas where I think it's obviously operational performance, but I think also on other areas where we're really bringing our trying to bring our resources and our capacity together. I think another area that I noted from earlier was emergency preparedness and resilience. I think that was referenced in Simon's report as well. So thank you, Russell, for highlighting that, because it is actually a year on since we perhaps the leadership, some of our leadership changes occurred, and I just want to recognise and thank colleagues who contributed to the improvement journey we've been on and continue to go on. I'm sure regional colleagues sitting here would encourage us, if they were sitting here, to up the pace and keep the momentum and increase the ambition, which I think was part of the conversation last week. But I know that we're all ambitious for our patients and for our community, and that's really the common factor in our efforts to try and drive the improvement we've been seeing. So thank you, Russell, and thank you, everybody. One final comment from me, actually. It won't surprise you. I will pick up something on mental health again. As colleagues know, it's one of my areas of interest. But important point, actually. I was just going to say, obviously, I noted that a risk had been open about inappropriate out-of-area mental health placements. That's a common risk, I think, across systems. Due to delays in or due to insufficient capacity. I just wondered if there was a particular reason it had been open now, whether that was just a reflection of the need to ensure that more of our mental health risks were included on our risk register. Particularly also wanted to ask whether there were any, because we often talk about delays in discharge in acute physical health settings, but don't often talk about delays in discharge for mental health patients. And I just wondered if if there's anything that we can sort of illuminate around that for members of the public. So, Hannah, do you want to comment on the process point and the risk point first?
Yes, thank you. So yes, you're absolutely right, Krishna. So previously we had just two kind of quite broadly worded risks around mental health that kind of encompass the whole performance around mental health. What we've done, we recognise that actually be more beneficial to split them out. So you will see on my report and also previously on Mary's report and the committee report, there's a number of mental health risks that have been opened. It's not necessarily because they're new risks, but what we've done, we've kind of separated them out so we can more clearly monitor progress and hopefully they decrease over time. So it is more of a process issue in this case.
Okay, thank you. And Rob, do you want to comment at all about some of the challenges about out-of-area placements and flow issues that affect mental health patients as well?
Yeah, I think the inappropriate out-of-area placements is probably quite an interesting one because contextually we are still extremely good when you look at our performance nationally. I think what we're seeing at the moment is there is increasing pressures there, but in terms of overall performance on inappropriate out-of-area placements, we are one of the higher performing in the country. So I think that's quite important to bear in mind. Clearly, Krishna, as you know, there is increasing pressure across all mental health services, inpatient services across the country. So that is there, and clearly, given where we are with our broader plans, just a few inappropriate placements do carry quite a significant financial risk as well. So it's probably appropriate from that perspective, but overall we are highly performing on that. I think the other ones you've got there we've talked a little bit about today. So the point which is picked up earlier is about recovery times we have for this. So children and young people access. I think actually we've got quite a good story on that. We mentioned Lumi, the app earlier. That's part of a range of measures, and there's a procurement going on which kicks in from April next year around overall provision. So I think it's right. It's drawing out some of the key risks and challenges which predominantly relate to increased referrals and constrained capacity, but it probably provides a better picture of the pressures across the sector.
Great, thank you, Rob, and helpful, I think, to note that whilst that risk has been opened more, as Hannah said, from a process point, actually the performance in relation to inappropriate out-of-area placements is pretty good in comparison to others where it can be a significant issue, but it does, I think, highlight, it does raise obviously challenges both for the patient and their family, but also, has financial implications for the system in doing that. So important to note that. Thank you very much. Okay, I think, Mary, you were just asking us to note the ongoing performance challenges, recognising the priority areas and indeed the improvements we've already discussed, and obviously assurance around patient safety focus as well. So thank you for the report. We move on then to financial plan and delivery, please. And this is item 12, and over to you, Mark.
Thank you very much, Chair. So before I just talk about 24-25, I just wanted to mention 23-24 from an ICB perspective. Just wanted to report that both the annual report and the annual accounts for 23-24 were signed off yesterday by the ICB Audit Committee. We've had a clean bill of health from the external auditors, so we've got an unqualified opinion, and both of those documents then will be published at a later date. So that's good news that we've come to the end of the last financial year. So in terms of then 24-25, you'll see within page 2 of the report then, and Simon touched on it within his paper, we do have now an agreed financial plan with NHS England for the new financial year. The plan is in line with the required financial control that was set by NHS England, so they've given everybody a control limit for the new financial year. And our ICS then revenue financial plan is for an £18 million deficit in 24-25. This will allow us then to receive what's called a deficit support allocation. So NHS England will give us that allocation probably either in month 4 or month 5. And what it will allow us to do then is report an overall financial balance across the system from a reporting perspective, but it will also give us sufficient cash from a cash flow perspective to ensure that we can cover all of our planned expenditure. Within the plan then, there is a requirement across the ICS to deliver £117.8 million of efficiency savings. So that's 6.6% of our total allocation. So that is quite a high level of savings. And we are monitoring those very closely, both across the ICS, but I also know at trust committees and boards that's been very closely monitored, and plans are in place for the majority, if not all of that, to be delivered during the financial year. We're also looking quite heavily as well within the plan around agency expenditure. So this is an area we've discussed previously, and again a real concerted effort now to try and reduce that level of expenditure again. So the plan looks for an agency expenditure level of around 50 million in 24-25, and that is a big reduction on where we finished last year. So we finished around about just over 70 million in expenditure last year. So again, we are hoping to see that step down. The plan also requires us to go a lot further on elective recovery and productivity. So you've heard in all the other updates about the work that's been done around productivity and going further, and the additional facilities and resources that are now there. The big push now is on productivity and maximising that so that we can earn what's called elective recovery funding. So additional resources from NHS England for going further on reducing elective waiting times, backlogs, and going further than the plan that they require us to do. So again, that's a big part of our plan. It's also worth saying our plan, in line with NHS England planning requirements, assumes there'll be no further industrial action. So when we set the plan and agreed the plan, those are the assumptions that were made. Now we know recently we've just seen 5 days of junior doctors industrial action. That will work its way through when we look at the month 3 financial reporting, but at the moment we've only got month 2 at this stage. So again, we just need to understand the implications of that and how that will be picked up then and addressed with NHS England. So as a result then of having a deficit plan, there are some implications now under the NHS England financial regime. So the implications of that are that we've had our capital allocation reduced by £2.5 million. So that does present some challenges for us, and it does put some more pressure into the system. We've already talked about some of the digital things we'd like to look at and need to go further on, some of the equipment risks and challenges, and we've got a lot on ongoing backlog maintenance that we need to address. So our programme has been reduced. It's been predominantly reduced in both of our acute trusts, and plans now have been realigned in order to live within that reduced capital allocation. So that is one of the consequences of having a deficit allocation. Saying all of that, we have got a plan. It's been agreed, and we've now got to work to deliver it, which I know has been touched upon already and is a key part of what we need to deliver this year. So within the paper then, we have monitoring up to month 2, which is May against this revised financial position. So at month 2 then, across the whole ICS, and you'll see this on page 3, our actual year-to-date deficit is £19.5 million, which is £1.1 million behind our phased plan. So a little bit behind already at month 2. It is worth saying this is before the inclusion of any of that deficit support allocation. So that's all outside of this at this stage. The month 2 then variance is predominantly driven by Wye Valley NHS Trust, which is slightly behind on its efficiency programme at month 2. I know the Trust has reviewed the programme. There's been a lot of internal discussions at Trust committees and also as part of the work and the actions that are being put in place around the efficiency programmes with the divisions and directorates. And further schemes have been identified and will be brought online probably in month 4 or month 5, which would hopefully allow us then to start to recover that position. Overall then, our efficiency plans across the whole ICS are slightly ahead at month 2, which is good news. Now, we've still got a lot more work to do on our efficiency plans. There's no two ways about that, but we've made a very good start. We need to keep that momentum, we need to keep that pace, and we need to see some of the step up in the phasing and how those plans come online as we continue through the financial year. We then our agency expenditure then. So again, agency is a little bit behind where we expected it to be at this point. Again, I know there's a lot of work happening within each of the individual trusts and through each of the committees and boards on the controls and tight grip that we've got in place around addressing agency reductions, and that's around looking at agencies that are not on frameworks, but again, agency shifts and what can be done differently. And we are seeing a switch from agency into bank. That is a good thing. It gives us some more flexibility, and again, it also gives us more control over the prices we pay. So I'd probably summarise, Chair, at this point, whilst it is very early in the financial year, it's great that we've got a plan agreed, but as we said, we've got to deliver it. The tight grip we've got on spending controls, looking at our efficiency plans, the enhanced focus on workforce and recruitment, including agency, we just need to maintain. We need to keep that grip and ensure that as we go through the financial year, we deliver the plans that we said we would, and then really start to move into looking into the medium term. And as Simon touched on earlier, then how we start to address this and move our financial plans and our financial position in the right direction. So I'll stop there, Chair, and I'm happy to take any questions.
Thank you, Mark. So any questions or comments on the paper? David first, please.
Thanks, Christian, and thanks, Mark. And it's great to hear that we're a little ahead on the efficiencies at this, although it's early, but great to hear that. I'm not sure if it's something which I've misunderstood on page 2, but where we have the efficiency saving for the ICB of 40.2 million, that figure feels unbelievably challenging if you look at our internal expenditure within the ICB. Does that actually represent support from NHSE? Is that what that figure is representing?
No, so that figure includes a number of things, David. So there are specific programmes of expenditure which we have targeted around prescribing and also looking at continuing healthcare, ensuring we get a maximised value for money in those areas. The other elements then that are included within there, again, as part of the plan development and some of the conversations with NHS England, we've had to make decisions on things we would have liked to do and spend money on around service development or further investments that we've just had to say we can't afford to do this year, given the financial position. So therefore, we've released them in order to support the overall financial plan of the system, and therefore there are additional efficiencies that we've put in order to get to a control total that NHS England could agree.
Okay, thank you.
Thank you, David. Mark, please. Mark Yates.
Thank you, Christian, and thank you, Mark. My point or question, Mark, is around, I think, presentation more than anything else. And I'm conscious that obviously this is a public meeting and members of the public listening in. It relates to agency. broadly, I think we're looking to reduce our agency spend by about 20 million. I think I heard you say, and certainly my trust is headlong into that and doing our bit, and we're actually on target. In fact, maybe just ahead. But the key thing I think we need to remember is if we reduce agency spend by £1 million, that doesn't reduce our spend by £1 million. And that can sometimes confuse. So, for example, in my own trust, I know because converting agency tends to be getting more bank staff or more substantive staff. So the expenditure is still there for the staff, just that it's cheaper. So, for example, £1 million in my trust reduction on agency spend translates to less than a quarter of that in actual reduction of spend. So in terms of presentational purposes, I want to ensure that everybody's aware that when we say we're reducing by 20 million, that is correct in terms of the spend on agency, but not correct in terms of the expenditure on staff.
Mark, do you want to comment on that?
That's absolutely correct, Chair. Mark is absolutely right. So what we're really targeting is the agency premium, which we know the premium is around 25% compared to if they were substantively employed through NHS trusts or on our bank. So we're really targeting the premium, and within our workforce plans, we've looked at how we can do more in terms of the switch between agency staff and either bank staff or substantive staff. So Mark is absolutely right. We're not just saying we're taking 20 million out in overall workforce cost. We're targeting the premium element and looking at the switch. And we've built that into the savings plans and also the workforce plans and expenditure plans for the year.
Thank you. So the important point is the sort of swapping out, isn't it, of agency for substantive or bank workforce. And of course, I think recognising that will help us in quality terms as well. It's not just a financial outcome, it is a quality outcome. Not to say there aren't very good agency staff, but of course, if you have substantive staff working consistently and providing continuity of experience within any setting, that is clearly more helpful and better for our patients as well. So it's a sort of genuinely important ambition for us to achieve, and because obviously recognising that it's the premium cost of agency that we are targeting, but it's still a significant part of our efficiency plan. I know I've asked this question before, but just again, I think for assurance really for the board, Mark and colleagues, how confident are we around the grip that we've got and our ability to sort of demonstrate that we are really looking at and challenging the ask around every use of agency and shifts, and we've got the kind of rigour around these processes that we need to ensure that we have a realistic chance of delivering that plan. Russell.
Can I make a suggestion, Christian? We ask Stephen, Jane and Robert that question as the three biggest spenders.
Very happy to ask that question of colleagues, if colleagues would like to answer. Stephen?
Can I go first? Yeah, I can go first. Yeah, so we've got quite substantial processes in place, and we're constantly tightening them as we go through it. Particularly for nursing, that was one the trust was well on with into last year, and now we're catching. I think it's safe to say we're making substantial progress around medical agency, which is substantially the bigger spend really. Might be low volume, but it's significant. In terms of how we targeting off framework, we're now down we've only got 2 off framework workers, and we've actually managed to move some off framework onto framework, so we're working around that. I think the other bit I would just put as context for Worcester Acute as well is people will remember last year we did a substantial amount of insourcing, which is where we use external companies. And I think, to use Mark's favourite phrase, it was just a pound in, but it was a pound out, made no contribution at all really to any of it. And we've seen a significant substantial reduction in that. which is why our bank figure looks higher, because that's how we're paying a lot of our medical staff, because we work with NHSP. So there's still a lot to go out there. I don't underestimate the work, and particularly the work we're doing around job planning, but it's starting to feel like it's getting into much better shape, which you see through the month 2 and month 3 figures that we've seen.
Thank you very much, Stephen. That's really helpful, and it's that sort of granularity that you've been able to share with us, which I think gives confidence to the board. Jane?
Thanks. Following really what Stephen's, I mean, 6% is a huge challenge. The elective surgical hub that opened last week, that's a really significant opportunity for us in terms of ERF and putting more income into the bottom line. We've seen our month 3 figures, and they're broadly in the same place as they were at month 2, which is a positive. And really just a lot of scrutiny and focus right through the organisation, down to each budget holder in terms of holding people to account for their budgets. So yeah, huge amount of work and focus going on.
Thank you, Jane. And Rob?
Yeah, I think the question was, can we provide assurance we've got appropriate controls and measures and all that? Yeah, absolutely we have. I mean, agency is led by my Chief Operating Officer, Executive Nurse and Medical Director, which I think Krishni just reads across to you. This is about quality of care as well as efficiency. We've got an ambitious plan. We're building on improvements we made last year. Yeah, we're on track at month 2, and I'm reasonably confident that we'll get there. Clearly, there's a lot of things that can happen through the year, but we're very focused on it.
Thank you, all 3 of you for commenting and contributing to that. And I think Rob, I think Mark, you wanted us to note the position at month 2. You've updated us that there is an adverse variance to plan at month 2 around 1.1, but you're positive, I think, overall with the progress that we've made initially. I think we do need to recognise that month 3 will include costs relating to industrial action, but those we were specifically asked not to account for or assume in our numbers. I think that's right, isn't it, Mark? So we will see the outcome of that in month 3 reports, but recognise that we were asked not to plan any financial elements relating to that. Any final comment, Mark, at this stage, or are you happy to close the item?
I'm happy to close the item, Chair, if there's no further questions.
Okay, thank you very much. So we note the position, and thank you everyone for questions and contributions on that. So our final report today is the Board Assurance Framework Report, and it's over to Hannah for that.
Okay, thank you very much. So this report summarises the overall position with regards to ICB objectives, priorities, the assurance levels, and the position with regards to key escalated risks. So we always try and make this report as easy to read as possible, acting on the feedback that we receive that we are really grateful for. So what we have done this time is we have inserted, as you will be able to see on page 3, an overall position, summary position of all the ICB objectives, assurance levels, target assurance, and any movement since the last report. So this is really just to provide a bit of at a glance, 1-page overview of the entire board assurance framework. Of course, the much more detailed position, detailing every single priority and where we are with regards to controls and assurances, is then included in Appendix 1. So then the page 4 of the report gives an overview of all our escalated risks and some of the drivers behind those, which a number of those we have already discussed today. Unsurprisingly, a lot of them relate to Objective 4, which is operational delivery. And then finally, page 5 to 7 lists all the key risk updates. Against a number of those will have been included in our committee report and QRD report that Mary presented. So it is just an overarching position. Detail is all there, and we're happy to answer any questions or draw any conclusions.
Thank you, Hannah. any questions or comments on the board assurance framework? Vicky, please.
I think just a comment to start with, Krishni, because I don't underestimate the work that Hannah and the team have undertaken to give us this comprehensive overview of our risks. I think QRD's focus has been particularly on the areas that perhaps haven't moved for 6 months or more that we then flag up and have a discussion on. I think bringing this up as the last agenda item nicely triangulates with the reports that we've been seeing today, and particularly to the points that Mary's been covered in terms of operational delivery and some of the progress that's been made. And I think probably QID will need to come back to actually what are the factors that enable us to then move something that hasn't moved for quite a while, and focus on those success measures. But I think it comes to Russell's point that he made slightly earlier, which is about that partnership working. So I think it nicely triangulates that, bringing this in as towards the end of the agenda. So thank you, Hannah.
Thank you, Vicky. Just really an observation, and I think the report is really helpful, Hannah, and it very easily, which I think is your intention, kind of highlights for us where our sort of key areas of focus should be. And I think I think it's fair to say, and the report highlights that objective 5 and the items within that are probably the areas that appear to be more at risk, and I think the report references that. I just wondered if we want to say any more about that, and it might not be for you to say, but is it David who's the lead on that? So I'm not sure, but Hannah, I'll let you decide who can comment on that.
Yeah, I mean, I would say objective 4 and 5 are really the ones where we would probably focus the most. Objective 5 is one that we there's a real collation of kind of items. It's, from kind of provider collaborative development to enablers. So our digital agenda would sit there, workforce and so on. So it does make it quite broad ranging and a business strategy and system focus. I think there are a lot of risks there. Most of them are amber. So I suppose in some way that's not the highest risk rating area. I suppose objective 4 is that, but yeah, it is kind of on a par. I think any more detail would go to David for that.
And David has helpfully put up his hand, so I shall just ask him to come in to comment. Thank you, David.
Yeah, I wasn't going to add too much more detail, but just to emphasise really that they're big strategic transformation projects. So therefore, I think it is right that we're kind of recognise that some of the risks are slow moving. They're not kind of immediately tackleable overnight, if you like. So we do keep an eye on them very closely, both in this committee and at Strategic Commissioning Committee, and through programme boards as well. So conscious of that, and we'll continue to do so going forward.
Thank you, David. That's helpful. I think one other area I'd just like a brief comment on, if I may. We obviously priority risk area, the first on the list is planned NHS strike action. We've had the junior doctor strike action recently, and the risk score increased as a result of that. I know we touched on in Simon's report, there was a reference to potential collective action from primary care and colleagues around the table who are primary care representatives, inverted commas, or members of the board who work in primary care, did acknowledge that there might be some conflicts of interest in relation to this. But I just wondered, Simon, from a public perspective, members of the public might be concerned about what that element of collective action might mean for them, whether we think that there is an further increase in risk as a result of that, or whether our risks remain broadly as they are outlined at the moment.
Yeah, thanks, Krishna. And I think the risk summary is reasonable. I think with the collective action from general practice, there is a slightly unknown element that we don't quite know how all of this will play out in practice. I think there is the view that possibly is right to some degree that actually some practices have already started taking some elements of collective action in terms of restricting access. We will watch this very carefully. We have got some pretty well established now processes where we are managing this type of action. The Junior Doctors Industrial Action, I must pay tribute to the teams of people that did a fantastic job really. We had excellent performance, particularly in urgent care during that period, and actually I think our cancellations were much lower than they could have been. So we've got ourselves in a position where, yeah, unfortunately we've had to get quite effective as a system at managing this action. The general practice stuff is a little bit different because it's going to be an ongoing thing. Of course, as well, we would encourage all parties in the conversation to keep discussing these contractual terms and conditions, and we'd hope that a resolution could be found. But in the meantime, while there isn't a resolution, we have got some good processes. We will watch this very carefully, and where necessary, we will try and find alternative provision. So if there is an issue with, for instance, general practice appointment capacity, and we're finding patients presenting in other parts of the system, we would have to come up with some creative solutions to trying to meet that need in those other parts of the system as well. So it's a fairly movable feast, but I'm quite confident that we've got the right systems and processes in place to manage that.
Okay, thank you very much, Simon. So if there are no further questions on the Board Assurance Framework Report, we are asked to receive that and gain the assurance that we need in terms of our management of the risks that are highlighted against our objectives. So thank you very much. We have actually quite well ahead of time, very efficiently got to the end of our agenda today. So I really just want to take the opportunity to thank partners, because this is all about us working together, and the improvements we've definitely noted in this meeting are a result of that collective and collaborative working, which is very much appreciated. But also, very importantly, to thank all our staff, who I know colleagues around the room would want to echo for their effort. It's not an easy environment for people, and we really just want to acknowledge everything that people are doing to support our patients and our community, which is what we're here to do. So thank you, everybody. Thank you for your contribution. Thank you for ensuring this meeting ran as efficiently as it did today, and look forward to seeing you at our next meeting, which members of the public might wish to note is 18th of September at 9:30. Thank you, everybody, and have a good day.